On now? There you go. Sorry about that. So the AWAEM Research Funding Award, it has a couple of purposes. It supports projects that are aligned to the AWAEM mission, and you can take a look at the AWAEM mission on the website. And also support AWAEM members in their research efforts, kind of anywhere within their, the spectrum of where they are within their training or faculty position. And it really is looking towards the promotion, the retention, the advancement of women in academic emergency medicine. We often do unfunded work, and so this is a way to maybe mitigate a little bit of that. It's not a lot of money, but it's just a little bit of funding. This will help. It's something to add to our CVs. It's a national talk, and so for that reason, it was created to kind of help support and encourage early researchers and mid-career researchers within AWAEM. So the application, in case any of you are interested and want to encourage any of your residents or fellows or junior faculty to apply, it's ideal for pilot projects that's not being funded by another source. Very minimal requirements, a very quick and easy application. We made it intentionally very short. And there's really very few obligations. A periodic update, a national talk the next year, and we usually start the process in the early fall, and you get money in hand by January 1st of that next year. So within a few short months, you're able to get that funding to start your projects. And projects are completed over the course of one calendar year from January to December. So the goals of this talk basically are to allow our researchers who were awarded the funding back in 2023, that calendar year, to present the work that they've done. It may still be in progress, it might be completed, but to present some of the work that they're doing, disseminate their research, and generate ideas, and maybe have a conversation with anyone who might have any suggestions on the work that they're doing. And also to stimulate ideas of the audience. So if you have, again, if you yourself are part of AWAEM and you want to apply for this, or you have a junior faculty person, to stimulate ideas based on what you're hearing our amazing researchers do, it often will generate ideas for yourself and what you might want to do. So this, I'm really proud of this slide. I show this slide every single year, and every single year it grows. So we've had this since 2020. We're on our 5th funding cycle. So we've just given out money for the 2024 year. In 5 funding cycles, and really only kind of fewer than that, we have funded 22 projects, over 80 investigators, and last year when I put up this slide, there were only 2 papers on this. In the last year, it's grown. We now have at least the 7 that I know of, and there's probably more in the works. And they're national presentations, new research partnerships, further studies, grants people are putting in for. It's really kind of really catapulted a lot of people, and with just a little bit of encouragement and a small amount of funding. And so I'm so proud of this slide just to see kind of how it grows. And next year there won't be enough room for all of the papers, I'm sure. So today we have 5 presenters, and I'm not going to read their titles. They will introduce themselves, but Rebecca Barron from UMass Medical State Bay State, and then we'll hear from Jennifer Carey from UMass Chan, also Bay State? Not Bay State. Sorry, I thought that was wrong. I apologize. Then Shubhi Goli from Stanford University, Michelle Lin from Stanford, and also Preeti Panda from Stanford. Different parts of Stanford, but really good showing last year. So I'm going to step off the stage. I'm going to hand the podium over to Dr. Barron, who's going to tell us about her study.
Thanks, Pooja. So hi, everyone. My name is Rebecca Barron. I'm an emergency physician at Bay State Medical Center and assistant professor of emergency medicine there. And I'm going to be discussing preliminary findings from our qualitative study on barriers to and facilitators of telesane implementation in emergency departments. So as Pooja mentioned, this was funded by an AWAEM research grant, for which I'm very grateful. Other than that, I don't have any disclosures. So the use of dedicated trained sexual assault forensic examiners, or SAFEs, which includes sexual assault nurse examiners, or SANEs, has been demonstrated to improve care for ED patients who have experienced acute sexual assault. But a major problem is that the availability and coverage of these examiners in the US is inconsistent at best. Telesane was developed as one strategy to increase safe availability for ED patients, but although it's been shown to be feasible and acceptable to clinicians and patients, it's rarely used. So this study was aimed at exploring the barriers to and facilitators of telesane implementation in EDs. So we developed an interview guide, which was based on a couple different implementation science frameworks, the consolidated framework for implementation research, and the theoretical domains framework. We conducted semi-structured interviews with a purposive sample of ED clinicians and administrators, which included both physicians and nurses. Participants were given $50 Amazon gift cards for their participation. The interviews were recorded, transcribed, and analyzed, and salient themes were noted, discussed, and organized. We are still conducting interviews, especially with folks who have more experience with telesane, to achieve maximum variation sampling, and also to reach theme saturation. So far we've interviewed 9 participants. Participants have worked at EDs in 4 different states. 2 so far have had experience with telesane. 4 were men physicians, 5 were women with nursing backgrounds, and so far all have been white. And so I'm going to describe some of the themes that have emerged so far. So in terms of barriers from the perspective of the outer setting, participants described the lack of access to telesane, the current existence of in-person SANE programs, and the disconnect between telesane and local resources. In terms of the inner setting, participants described the logistical, administrative, and educational burdens of setting up a telesane system. So I'll just read a couple of quotes. I think, these are from participants, I think telesane could be a resource utilized. I don't know that it should be the system per se. I think it could be, if in-person SAFE wasn't available, then we could do this for you, but I don't think it should transition and take over the standard of care. Another participant said, I think we'd probably be interested in telesane. We would probably see it as a backup, like if there's a delay over a certain amount of time getting a SANE nurse in person, then we would use this as a backup. I think we would still prefer to use a nurse in person if we had that option. And then in terms of individual characteristics, participants described satisfaction with the status quo, fears about the quality of telesane, and also concerns about the patient's perception of telesane. And then finally, in terms of intervention characteristics, participants described perceiving telesane as potentially impersonal, as contributing to the fragmentation of care, and also as being potentially resource intensive. There's a couple more quotes from participants. I think that it's more therapeutic having somebody there in person, having this one person care for you, doing it all for you. You know that this person has trust in you, and they've developed this relationship with you. Another participant said it's hard to be that comfort to the patient when you're in a box, in other words, an iPad. So shifting gears in terms of facilitators, participants, in terms of the outer setting perspective, participants described the current inconsistent availability and coverage of in-person SANE. They also described the vulnerability of these programs to being discontinued. In terms of the inner setting, participants described acknowledged acute sexual assault care as something that warrants both expertise and timely addressing in the ED. And they also recognized SANE or SAFE as the gold standard for providing this care. A couple quotes to illustrate this. I think that you need to have specific training in the care of sexual assault patients. We as physicians don't get very much. Got a little bit in residency and a little bit more as an attending. A lot of our nurses are well trained, but having people who are specifically trained for it is really important. Another participant, I think that it should be a SAFE certified nurse or someone who has gone through our state program providing care for patients who have experienced acute sexual assault. I don't think they necessarily have to be active in the program, but I think that the program is standard of care and teaches you the right way to do it. And then in terms of individual characteristics, participants described ED clinicians' discomfort with providing acute sexual assault care. And then in terms of intervention characteristics, telesane was perceived by participants to fill gaps in current SANE availability and coverage, also perceived to provide patients with the rapid access to SANE that is viewed as standard of care, and then also offered bedside ED clinicians with support and expertise. And finally, a couple quotes illustrating that. So I think that it's really hard for nurses to feel confident when they're doing forensic evidence collection. And I know a lot of nurses don't like it just because you have a high chance of being called into court. They're so worried about, am I writing the right thing? Am I collecting the evidence correctly? Am I doing it right? So not being exposed to it that often, it's a really high anxiety procedure for our nurses. Another participant said, our current nurses are very, very scared, timid, and do not want to take these patients because they're afraid they'll do something wrong. They'll have to testify or be called into court, and they don't know how to talk to these patients. So in summary, I think broader successful telesane implementation will likely require a local champion, administrative support, sufficient resources, and also both clinician and patient education. And perhaps not surprisingly, telesane would likely be particularly appealing to EDs without current consistent in-person sane availability and coverage. Thank you so much, and if you have any questions, please feel free to email me.
Hello, my name is Jennifer Carey. I am an associate professor at UMass Chan in Worcester. And today I'm going to be speaking to you about a project that I'm currently doing, which is looking at attrition among mid-career academic emergency medicine faculty. So as most of us in the room are probably aware, there's been a lot of attrition in physicians in the workforce over the past several years. Almost 150,000 people left in 2021 and 22. And a survey from 2023 said over a quarter of physicians are considering leaving clinical practice altogether for non-clinical positions. So the reasons that we hear about are really multifactorial. We hear about burnout, COVID-19 pandemic, administrative issues, all types of different things. And so specifically what I wanted to look at were, as I said, this group of mid-career physicians in academic emergency medicine. So the study is a survey study, and we're looking at both why physicians are leaving, if there's any steps that departments are taking to try and combat that, where physicians are going next, what effects this has on academic productivity, because if you think about it, leaving your job, even if you're going from one academic center to another, that's quite a break in time in terms of when you're able to do some of your research and writing and that type of stuff. And then importantly, we want to look at gender differences. So we're approaching from two angles. Part one is looking at this from the chair's perspective, and part two is looking at it from the physician's perspective. And we want to see how they compare. So for part one of the study, we identified chairs at 120 different academic emergency departments who were serving in that department between 2020 and 2023. We developed a survey for chairs, and we sent it to them through Qualtrics, and they were sent up to 5 reminders if they did not respond. I wasn't expecting a large response rate, but unfortunately the response rate was lower than I was hoping for. So the data I have is interesting, but because of the low response rate may not be fully illustrate what's going on across the country. Part two of the study, I'm planning to be able to recruit more people and get more data. So today I'm presenting to you the data that we have for the chairs. So in terms of the basic demographics, the respondents, 73.7% were men and 78% white. We have respondents from all around the country. And so first we asked about attrition. And so chairs at 10 of the institutions reported that they had mid-career faculty leave. And so among these departments, there was a total of 23 positions that we collected data on. And the average number of physicians that left these departments was 2.55, as you can see. Gender was only reported in 19 of those cases. There were 9 women, 9 men, and then one was reported as non-binary other, and they didn't provide the specific gender information for that individual. So when we look at the reasons that the chairs perceived that the faculty were leaving, we asked them a series of questions and let them give other answers as well. And so you can see here that the difference between men and women, and we did include the non-binary individual, however, there's only one respondent, so you can see the number there, but I'm going to speak on the spectrum men and women. So for women, the chairs perceived that none of them left due to salary issues. However, 56% were burnt out. Interestingly, men, some of them did leave because of salary issues. And burnout was also higher on the list, but not as high as in women. We asked whether or not the chairs tried to negotiate when their faculty were leaving to try and retain them. And you can see there's actually a fairly big difference here between the women and the men. 33% they said yes for women, and 55 for men. We asked whether or not their department made any changes to try and retain faculty, and 36% said they did. The things that were implemented by chairs and departments were exit surveys. They implemented more regular communication between the leadership in the department, so either the chair or the division directors, including division lunches, one-to-one chair meetings. Some places reported that they increased compensation and increased the protected time. And then other institutions reported that they hired more faculty to help offset the workload that the physicians were facing. In terms of whether or not these changes that they were implemented actually made a difference, one respondent said that it was helpful for them, but others said it was too early to tell. We asked the chairs who said they had no attrition what they thought the reasons were, and they said a healthy work culture, so there's an emphasis on work-life balance. Faculty feel like they have ownership and they have a voice in the department. They talked about scheduling, like fair scheduling, fair compensation, camaraderie between the group. And they also mentioned that they are seeing attrition, but they're seeing attrition in the lower ranks and not in the specific group. So the next part of the study is to get the physician perspective. We're currently recruiting and hoping to roll this out in a couple of weeks. And so if anybody has any faculty that they know of who might be eligible for the study, I encourage you to scan the QR code so we can recruit. And so it's any academic position who left between 2020 and 2023. And we're looking at mid-career. So actually, I forgot to mention earlier, mid-career for the study, it can be defined in different ways, but we said anybody who's assistant at 5+ years or associate professor. And if you're not sure whether or not this person that you're referring is eligible, you can just let me know and I'll look into it. Thank you. And I just want to thank the folks that helped me out with the study.
Good morning, everybody. My name is Shubhi. I'm a third-year pediatric emergency medicine fellow at Stanford, and I'll be talking to you today about my research in the lactation practices and preferences of PEM fellows. So lactation is scary, and then you pair that up with being a trainee and being in the emergency department, on top of dealing with how unpredictable it is, how high the stakes are. Sometimes you can really feel like a bad physician, a bad colleague, as well as a bad mom. So we know that there are a lot of national policies that actually do encourage a culture of support for nursing physicians. These are a few to highlight, mostly the Affordable Care Act, ASAP, the American Academy of Family Physicians, and the AAP. But few programs have released local or established policies. So we know that over the last few years, several studies have aimed to better understand the lactation culture of physicians and trainees. But a lot of that data is heterogeneous, both in terms of number of participants, the types of trainees they're looking at, as well as kind of the factors that they've looked at. And so overall, the qualitative and quantitative data is still limited. And to our knowledge, no studies have specifically looked at the overlap between emergency medicine and pediatrics. So in emergency medicine, a lot of times it's a culture that we do know about, how hard it can be. And pediatrics more historically has supported lactation as well as the health and well-being of all children. So with our study, we sought to evaluate PEM Fellow and Program Director awareness of departmental and institutional policies. We aimed to describe PEM Fellows' personal lactation goals and practices, and then we also hope to identify PEM Fellows' perceived barriers and facilitators to lactation. This was also a national cross-sectional survey study. It was distributed via the PEM Program Director listserv last year in spring of 2023, so about 9 months into the academic year, so that even the first-year trainees had some time. We had an initial short 10-question Program Director survey that once the PDs received it, they would then forward the larger fellow survey to all of their trainees. And fellows were then asked to self-identify with the language that you can read here as having current or potential ability to lactate. We wanted to be inclusive of everybody. Thank you to AWAEM for helping recruit fellows. We were able to recruit quite a few, which was awesome. And then data was summarized via frequencies and means, and is currently under review. So we had really good participation from program directors. We had 71% complete the PD survey. They estimated that they had a total of 461 fellows, of which 310 were study eligible. And from those trainees, we had 115 or 37% actually complete the trainee survey, which is in line with a lot of other studies that have been sent out via that same listserv. And from those 115, I have the numbers here for those who had previously lactated, are currently lactating, hoping to lactate, and then do not anticipate lactating. So we had kind of a good distribution amongst all of that. In terms of our results, the mean age was 33 for those who participated. Majority were in a relationship or trained in pediatrics. 59% had or hoped to have a child during fellowship, and 92%, so most of them actually lactated or hoped to lactate after returning back to their clinical work. With regards to AIM-1, lactation policy awareness, 88% of PDs reported experience working with lactating trainees, but only 57% reported that they were aware of a policy that was applicable to their trainees. And even fewer fellows reported awareness of that same policy if it existed at their institution. Despite that, the culture was perceived to be generally positive, so 82% of trainees actually still felt that the culture surrounding lactation at their institution was relatively positive. However, when we looked at the data a little bit more closely, only 61% discussed a plan with their PD prior to return to work. 49% received any sort of planned guidance, and 42% did not think that they would meet their lactation goal upon returning to work as well. So what were their lactation goals? Fellows desired to lactate 11.5 months, and for the previously lactating group, I don't have this on the slide, most of them met around 11 months, so did not meet that 11.5. Pumping on average for an 8-hour shift. On average, they pumped about twice, spent about 7 minutes walking to and from their chosen lactation space, and then spent 21 minutes actually pumping. So if you kind of add that all up, it's actually less than an hour for their full shift, or less than a half an hour per actual individual session. So definitely things that we can, I think, highlight moving on. And for the final aim, when we were looking for other more specific things that we can work on improving, one of the things we identified was that PDs can be a little bit more flexible when these trainees are returning back to work in terms of the rotation that they're on. So fellows consistently reported that research, toxicology, ultrasound, and anesthesia were thought to be a little bit more conducive for lactation as compared to, say, like EMS, adult emergency medicine, or trauma. And then with literal room for improvement, 67% of fellows reported that they did have a dedicated lactation space available to them, which is an improvement from prior numbers that have been reported previously. However, only 34% actually planned to use that space or lactated in that space. And some of those factors that were highlighted were just, again, it was too far, it's a shared space, it's often unavailable, they still want to be performing their clinical care, and then also that they're insufficiently equipped. And some of the things that they identified is that they would hope to have is computers, comfortable seating, and then I thought soap was another one that's like an easily identified thing that can be improved as well. So in conclusion, most fellows are likely to have lactation experience during their fellowship. However, the support that they receive from their program directors, institutional policies, and lactation accommodations is variable. And so how can we facilitate this? We can definitely improve all the things that we talked about, but also work on scheduling accommodations, and then also adding improvements to the lactation piece as well. So just a quick thank you to my research team, as well as to the many people who helped me with Qualtrics and reviewing the survey iterations via being one of them. And thank you, and those are my email addresses. I'll be at Emory next year, so thank you.
Hi everyone, I'm Michelle Lynn. I'm a health services researcher at Stanford University.
My project is researching equity in starting compensation among emergency medicine research scientists. So RESTART is the acronym that we chose. And this is my team. I feel very lucky to be working with these awesome AWAEM ladies who weren't able to be here today, but across institutions. So this is something that actually comes from the literature predominantly outside of medicine. I think we all are aware of gender disparities in salary, in promotion, and at the very top echelons of leadership, not only in emergency medicine, but across the house of medicine. When they've looked at this in a lot of the business literature, one of the key factors that they identify is this concept of the broken ladder rung, meaning that women start out unequal. So their very first positions, and often their very first leadership positions, are either later or less compensated or less prestigious than their male counterparts after accounting for their qualifications and stage of training. And this is something that we actually saw in a prior study that we did looking at differences between male and female chairs in emergency medicine. We looked at all their CVs actually and compared their qualifications. And it wasn't statistically significant because we didn't have a large enough sample of female chairs, sadly. But we did see that the time to first leadership position and the proportion was a little bit longer for women, and that men were 5 times as likely to have a leadership position in their very first faculty job. Again, not statistically significant, but 5 times is like a pretty big magnitude difference. So this is actually also happening in emergency medicine. So this is, and this compounds over time, right? Because if you start out unequal, and then every subsequent promotion and pay raise is compounded on top of that, then it builds up to millions of dollars in lost compensation. Understanding this, I wanted to dig into this a little bit deeper to try to figure out what can be done about it. We're often taught to negotiate, and that negotiation is the answer. So part of this is negotiation really the answer? So I chose to focus on research scientists specifically because I really wanted to do an apples to apples comparison. As we all know, there are different tracks in emergency medicine. You can be an educator, you can be an administrator, you can be a researcher, and the types of things that you might be offered in that first faculty position probably vary, and your needs are going to vary depending on what it is your goals are. We felt like this would be a more direct comparison. And the other piece is that a lot of what faculty are offered in a research scientist position is not related to salary. There are things like time, administrative support, research funding, and there actually is a huge gap with respect to understanding what is even available. So I think people don't even know what to ask for in these very first positions. So we conducted a qualitative study. Our primary outcome was, were there any gender differences in negotiation? And then 2, what did people even think to negotiate for? Because I can certainly say that I did not know when I was completing fellowship and going into my first faculty position. Our inclusion criteria were any EM research fellowship graduates from 2018 to 2020. We've had to broaden that a little bit, so I think we now go back as far as 2016 to 2022, just to ensure that we have a large enough sample. We're trying to go in random order, but trying to identify at least 1 male and 1 female graduate from each research fellowship program for a little bit of balance in genders. Our timeline has been a little bit delayed. It took us a long time to get the list of graduates from each research fellowship, so that's been the primary barrier. So we reached out to every program administrator repeatedly, and finally did come up with a robust list of over 100 eligible participants. And in the meantime, we were developing our interview guide, recruiting and training our qualitative analyst. So we actually only just very recently started interviewing. We are about, we've actually done 8 at this point, so slides were submitted a little bit early. A slight female predominance, so even though we recruit in equal numbers, the number of people who accept skews towards women. Reasonable geographic distribution, and I couldn't get the quotes in time for this, but there's a lot of variation in terms of what people are getting offered and thinking to ask for. And actually, of the 8 that we've done, only 1 or 2 have even negotiated. And some of the things that people talked about were a fear of rocking the boat, a fear of being said no to or being perceived as asking too much. And in terms of what they asked for, but far and away, I think time and effort for research was the number one thing. But a lot of them talked about things that were a little bit intangible, like mentorship. Like, okay, like the money didn't matter to me as much as the mentorship did. Most of them got some sort of research startup package. I certainly didn't get one, so it's nice to know that people are getting this and to be able to put out into the world that this is something that is standard that people are getting. Most people just kind of took what they were offered and went with it. So we're still interviewing. We've actually shifted our strategy to use our personal knowledge of people who might have negotiated to try to oversample people who might have negotiated to see if we can tease out whether or not there are gender differences. To see, if you did negotiate, how did that go? But we think it's going to be interesting, even if we don't find that, because there's so much variation in what's happening. So this is what we're doing. So we're shifting our strategy, like I said. We're still interviewing on average 1 to 2 a week, and we are planning to write this up over the summer. Thank you. Feel free to reach out.
Hi everyone. I'm Preeti. I'm one of the PEDS EM Fellows at Stanford. I'm excited to talk to you guys about my work on child trafficking in the ED. So just briefly about the issue, a big question I get is how did you get interested in this kind of work? And so I first encountered child trafficking when I was working at a charter high school in upstate New York. And it was the last place that I ever expected my 14-year-old student to be experiencing exploitation. And that was prior to medical school. And then getting into medical school and realizing at that time that kids who are trafficked experience a ton of healthcare problems and present to healthcare settings, including emergency departments, led me to continue this work. This is a map of the Polaris Project National Human Trafficking Hotline, just showing that, and it's a heat map showing all the places that they get tips and confirmed cases. It's a slightly outdated map, and so it's probably grown since then, but clearly you can see here that trafficking happens in all 50 states, in many counties and cities across the country, so very relevant. So the research projects that I wanted to briefly talk to you guys about today sort of stemmed from thinking about how can we tailor interventions and support services for youth who are experiencing trafficking in the ED. And we realized there's just a lack of data on health utilization and how these kids present to EDs and sort of where they go after that. And so that really motivated our research. And so our major goals were to understand ED utilization of youth experiencing trafficking. We also wanted to identify disparities as well in care for youth presenting for similar medical problems, which is something we're working on still, and so I'm not going to talk about that one today. And then I'd love to highlight some of our work with lived experience experts and survivors of trafficking that the AWAEM grant made possible. So the first study I just wanted to briefly talk about was looking at the effect of ED presentations during COVID. And so as you guys all know, COVID caused significant economic, social shocks, and people speculated that human trafficking would increase during the pandemic because of these stressors, but it wasn't explicitly studied. So we used the FIS database, which is a database of 50 children's hospitals across the country, and utilized the human trafficking ICD-10 codes to see what the changes were before and after the pandemic. And we hypothesized that there would be sort of a spike in presentation of children who were trafficked after the start of the pandemic. And that's the FIS. And these are the human trafficking ICD-10 codes. If you were not aware that a lot of people still don't know that they exist, but you're able to use these codes. And so in the database, we found about 250 children who were identified as trafficked before the start of the pandemic and about 650 afterwards. And they actually had pretty balanced demographics. But this was our main interrupted time series figure. And so the red solid line is our regression output, and the vertical dotted line is March 2020. And so if you see, like, right at the start of the pandemic, there was a huge spike in identified trafficked youth. The dotted line is our counterfactual, so that's like what would have happened in a world where the COVID-19 pandemic did not occur. And it was essentially modeled as an extrapolation of the pre-pandemic trend. And so it's most useful to look at, like, right around the time of March 2020. And so much more, like a larger increase than we would have expected, essentially. And that regression also corresponded to like almost a twofold increase. It was 1.92 was our beta coefficient. So our big takeaway from this study was, expanding resources and policies and programs to support trafficked and at-risk youth in pandemic and disaster situations would be a useful investment of our time. Another study that we did with this funding was to look at Childhood Opportunity Index and ED utilization of kids who present to emergency departments. And again, this was mainly to look at, if we have limited resources and we want to implement programs for kids who are trafficked, what setting in the emergency department is the best way to do that. And we looked at Child Opportunity Index, which is, if you're not familiar with that, it's sort of a composite marker of socioeconomic status, and it takes into account 28 different markers from the neighborhood and community level that might affect a child's opportunity, so to speak. And so we were hoping to characterize the range of socioeconomic and demographic characteristics and to understand any associations between child opportunity and ED utilization. And so one of the striking things we found is we had hypothesized that almost all trafficked youth would have very low or low child opportunity index, but about half of our cohort had moderate or high to very high. So for screening children, from that standpoint, we really need to look at a broader set of youth. Another interesting thing we found is that the majority of trafficked youth did not have low resource ED visits, so that's an ED visit without treatment or testing, like your ESI 4s and 5s. Which is something that was just sort of assumed about this population, but a lot of trafficked youth have high acuity visits, and so that's definitely something to take into account as you're designing programs and interventions to support this population. And then finally, I wanted to highlight our community engagement with individuals who have lived experience of trafficking. And so this is sort of becoming a growing best practice when you do work on human trafficking. There are actually a lot of survivors of trafficking who are involved in the movement, who are getting professional degrees and who want to be a part of our response to trafficking. So we used our grant funds to create partnerships with 4 individuals of lived experience of child trafficking. And they were diverse in experiencing sex and labor trafficking and in their gender identities. And we were able to compensate them for their time as expert consultants. Through our grant funding. One thing that was awesome was we built professional development funds into the grant. And so they were able to use that for, some of them are getting advanced degrees and didn't have funds to pay for like a thesis quarter and things like that. So it was actually really helpful, which was very cool. So they specifically looked at the results of our study and helped us create translational materials for organizations that are looking to respond to trafficking but are not as familiar with the research details. To help sort of increase the impact of our research. And then I partnered with one of them to create a toolkit and worksheets and sort of best practices geared towards both researchers and lived experience experts on engaging survivors in healthcare research. And we specifically focused on sort of non-traditional research that you wouldn't generally have community engagement with. So for example, my studies were all retrospective database studies, which are not traditionally, involving community engagement. And so we focused on how do you effectively and meaningfully do that. Thank you, guys.
Thank you. Those were all incredible. And I also want to commend you. I gave you a very short timeline, and you all stuck to your 8 minutes, which is fantastic, which means we have about 10 minutes or so for questions. If anyone wants to ask anything of any of our researchers up here, feel free to, I will hand you the mic if anyone has any questions. Yeah.
I just have a question for Dr. Panda. Super interesting research, but and maybe I just missed this, but how is it that you went about identifying these people? Because particularly, even, I mean, I see adults, and it's hard enough then, but I mean, to have a child speak up and say, yeah, hey, I'm being trafficked, you know, how did you do that?
Okay, can you guys hear me? Oh, yeah. Yeah, great question. So this was a retrospective database study. So we actually used encounters that were coded with an ICD-10 diagnosis for trafficking. And we used either current or past trafficking because that definition is very fluid and people get re-exploited. So yeah, it depended. So that encounter depended on either, generally in my experience, it's either, you know, a child is brought in by the county or by law enforcement or, you know, like for a SAEM exam, knowing that they have already been identified as trafficked. But sometimes in our hope is that providers are identifying this. And so providers are recognizing the red flags, taking the time to do, you know, build rapport, do an interview, and understand what's going on. And then at that point, you know, referring the child. But as you can imagine, we're probably vastly undercoding because of difficulties in disclosure and confidentiality issues, right? If your ICD codes are going to print out on your discharge paperwork, and just like providers not being aware. So it's definitely represents like an we're undercoding, but it's like one of the best markers we can use to get any data on this. So it's not perfect.
And actually, I was wondering the same thing, and I wonder if kind of using some of the community engagement work that you're doing might be a way to kind of educate healthcare providers into what are you looking for. If it's not an obvious thing, they're not coming in with the county, how can we all identify it just on our own? What are those little triggers and kind of things we should be looking for? So that's fantastic. Any other questions? Because I have some, but.
I would just comment that I feel like especially emergency physicians are vastly undereducated when it comes to, I mean, you talked about red flags, but we have one resident who is very active in this, but in general, it hasn't been rolled out to the faculty, and unless you happen to have been there at his lecture, I mean, I'm in Dallas, which is a huge area for trafficking. So, it's very disappointing. So in the future, maybe another one of your research projects would be, how to disseminate this information to look for the red flags.
So I have a question for Dr. Lin. I think it's striking, all of the disparities you're seeing in just this very early stage of work that you've done with the researchers. Can you reflect, can you consider the other components? You mentioned researchers, you mentioned the educators, you mentioned the operations, kind of those three major pillars within academic EM. Is there like a next step to think about those other buckets of academic emergency medicine and disparities? And if so, can you maybe reflect on what you think you might find there? Will you think there'll be differences?
Yeah, that's a great question. In some of our previous work, again, looking at who becomes a chair, we did look at which track they were on over the course of their careers, and in particular, their next closest position prior to becoming chair. And it's interesting. So about 60% of chairs come from operational backgrounds, which is unsurprising. But of the women, a majority of them come from educational leadership backgrounds, and the men predominantly, almost exclusively, came from operational backgrounds. And then if you go all the way to the very beginning of their career and you look at their very first leadership position, among the women, 60% of their leadership positions are in educational positions, and for men, 60% are in administrative positions. And,
it's a survey, so we don't know why, but at the very least, we are seeing among these very accomplished individuals, and perhaps there's some self-selection, perhaps there's some stereotype. I don't know, and I don't know the differences in compensation, between the tracks, but certainly there's some association with progression among the ranks, and I think it's something that we should critically examine. And is it because the men know that these are more, promising, better compensated? I don't know. So I think that those would be really great areas for future research. And I think when we finish this study, we'll have to think about what we want to do next.
I can keep going. I could talk to each of you for like hours because I think these are all so interesting. I want to ask Dr. Barron, I wanted to ask you a question. So you spoke a little bit about how some of the barriers to the SAEM nurses and the just kind of that hesitation, the fear, right, of being called to give a deposition or to be writing something wrong on a record that really has so much importance. And I'm wondering if and perhaps I missed this, but I'm wondering if the kind of the telesane versus in-person sane, is there a difference there in how people kind of present with that fear of from a provider side, or is it because it's telesane, people they're feeling more like they can actually engage better or worse, or can you reflect a little bit on that kind of that perception?
So thanks for asking. It's a good question. I just want to make sure I'm answering it appropriately. Do you mean more from the nursing perspective? Yeah. Okay. Yeah, so it's a really good question. And again, we only have a couple participants so far who have the telesane experience. But it seems like folks in general appreciate any support. And so I think the telesane, the main way it's been rolled out is you have a remote site clinician, and so oftentimes that is the bedside nurse who is sort of in the room with the telesane, collecting evidence, et cetera. And so it seems like that remote site clinician feels supported, by, or would feel supported by a telesane presence. I think one interesting thing that's come up though is that having an in-person sane sort of obviates the need to actually even have the bedside nurse in the room. This has come up more from an operational perspective where, especially the folks who had more administrative backgrounds, really appreciated more having an in-person clinician, sane come in. Because then it frees up a nurse to sort of continue doing their other clinical work. But I got the sense that both telesane and in-person, were sort of perceived as being expert resources that could be utilized by the bedside clinicians. I hope that answers your question, but if not, I can go.
And I have one last question, and it's actually kind of a combo for both Dr. Goli and Dr. Carey. What I struck with each of your presentations is your response rates were so dramatically different between both of your studies. No, they're totally different studies, but Dr. Carey, you had, I think it was 16% response, and then Dr. Goli, you had 70-something response. And I'm wondering, I could have gotten that number wrong. I'm wondering if you could each reflect a little bit on what strategies do you think could work? What worked for you, and what do you think could actually help in terms of increasing those response rates? Because that's kind of where all the data are, right?
Okay, I think this is working. So we had from trainees, we had 37% of estimated trainees, eligible trainees, reply. And I think part of it was assisted by the fact that I think people are pretty passionate about that topic when returning to work. So I think particularly with the recent wave, so that really helped. I think I don't know where those numbers came from, and I think part of it was the AWAEM grant. I think because we were helping give a little incentive to complete it. So even we had pretty good response rate for those who did not lactate or weren't planning to lactate as well. So I was really, really happy with that because it was like half and half almost. So it was really nice to get feedback from that population as well. But I think it probably the incentive helped, honestly.
I think also if you look at the stakeholders and when I receive a survey, I look at the survey and think like, oh, am I going to get something out of this? And is it going to benefit me? So I actually, going into this study, I was expecting that we were going to have a very low response rate from the chairs, but I think that we'll have a higher response rate from the faculty. And I kind of worked out the survey a few times in terms of how I would present it to the chairs, because I think that this is, I think that they could feel damaged if they say that they have a high faculty attrition and that they're losing people because their department isn't strong in all these different areas. And so I don't think that there was a lot of benefit, I would say, for a lot of chairs to fill this out. And again, that's why I was expecting a low response rate. I was hoping for more, but unfortunately we didn't get more. So like I said, I am expecting that we will get more buy-in from the faculty who are responding to the survey.
I think we're out of time, but I want to thank you all again for this amazing research and presenting this stuff to us and allowing us to kind of explore your world. This is fantastic. Thank you again.